Hey everybody, this is Joe Minardi and I'm here to give you a little bit of an introduction to using ultrasound to help guide your procedures, and I'm going to include in that some central IV access. So hope this is enjoyable for you. This is a topic that I like a lot, so let's go ahead and jump in and get started. I don't have any disclosures. There you go. There's lots and lots of evidence. This is just one of my favorite studies that could show you how much ultrasound can improve what you can do with procedures. So in a study of attending rheumatologists who are already very experienced in performing arthrocentesis and doing joint injections, who then learned how to do it with ultrasound, they showed a 300% improvement in their success rates of joint aspiration when they use ultrasound guidance. So I think that's a pretty telling study on how well ultrasound can help you improve your success and make you better at procedures. So, and how does it do that? Well, you can detect anything that's abnormal before you stick a needle in it. That's usually a good thing. You can see that vessel is clotted before you try to catheterize it. You can avoid trouble spots. You're often sticking a sharp object into sensitive anatomy, and there's usually a lot of things you want to avoid nearby, and so you can help directly visualize those trouble spots and avoid them. You can see the target directly, and you just do a lot less guesswork. Although we can use landmarks, actually directly visualizing anatomy is a lot more accurate way to do these things. So again, the fundamentals, kind of already mentioned this, almost any procedure that we do in medicine is taking a sharp object and targeting that towards some sensitive anatomy, and usually there are things nearby that we want to avoid. So in this example here, we see this is one of the most common, probably the first beginner ultrasound guided procedure we do a lot of times, is an internal jugular vein catheterization. And we can see here we've got sensitive anatomy, our target, which is the internal jugular vein, and then nearby we have things that we want to avoid: the thyroid, the carotid artery. Those are things we don't want our needle to go into when we're doing this procedure. So it just makes sense that directly visualizing the anatomy and the path of our needle as we do this procedure makes a lot of sense. And study after study shows better success rates, less complications, fewer sticks, and all around a better procedure. Now the targets can be anything, right? We can talk about vessels, but they can be nerves, joint spaces, any fluid collection in the abdomen, around the outside of the heart, in the chest, abscesses in the skin. It goes on and on and on. Now I want to make sure everybody understands that just because we're using ultrasound to perform a procedure, that doesn't mean it's a no-risk procedure now. The risks, all the same risks that are inherent to procedures, are still present when you use ultrasound. However, using ultrasound can decrease these risks. The infection, bleeding, injuries to nearby things like arteries and thyroids and nerves, all those things can still happen, but hopefully, especially if we use ultrasound properly and we have good technique, we can hopefully dramatically decrease the risk of these things. This is an important point. If you are someone who has learned to do all of your procedures by landmark techniques, you're not just going to add ultrasound to that technique. This is a whole different technique. Your hand-eye coordination is different. Your eyes are looking in different places. The movements that you do with your hands, the way you set things up, often are very different. So you should approach this more as learning a new procedure, not just let me add ultrasound to the procedure that I already know. Because that's often when I think people do get into trouble, is when they try to do their landmark technique, but then they're looking with ultrasound, so their hand-eye skills and coordination don't quite match up. So just approach this as if it's a brand new technique. It's like if you imagine surgeons for years who did open appendectomies, who then had to start doing laparoscopic appendectomies. The maneuvers and the techniques are very different. You're looking in a different spot, you're looking at a screen instead of directly at your patient, you're moving instruments in a different way than you were before, and they're really different techniques. And this is the same thing. The hand-eye coordination, the motor skills are significantly different enough that you should approach this as if it's a new procedure. I'd like to go over a couple of fundamentals. I think some of these, if you understand them well, will help you understand and adapt techniques to almost any procedure that you want to do. So the first thing I want to talk about is how, when we do directly visualized or dynamic procedures, how we orient the needle to the ultrasound beam. And I usually refer to that as in plane versus out of plane. And again, we're talking about how the needle is oriented in relation to the ultrasound beam. So this first example here, we see this is our ultrasound probe. The beam is coming out like this, and our ultrasound needle passes through the plane of the ultrasound beam, and so on the screen we should see something like this, hopefully, ideally, where we see the tip of the needle and the path of the needle all along our screen. We see it the whole way, and then we get this reverberation artifact that helps us visualize it. That is one common approach to many procedures, but sometimes we do an out-of-plane technique, so our beam here is slicing towards and away from us, and now our needle, it passes through the plane, but most of our needle is outside of the plane of the ultrasound beam. So this is an out-of-plane technique. And here what you'll see is you'll just see where the ultrasound beam strikes this needle, maybe here, and you'll see a little bit of bright white echogenicity with sometimes some reverberation artifact. And you can see here, no matter where the ultrasound beam is here, whether it's ultrasound beam strikes here or here, this looks the same on the screen. That's one of the drawbacks to this technique, but there are other advantages. So we're going to adapt different techniques to different procedures, and you'll see there are pluses and minuses for both. And there are also advocates for different techniques and different ones. Eventually you're going to decide what you like best for the procedure that you do. So the plane refers to how the needle relates to the ultrasound beam. So that's how we'll discuss this moving forward. And here we are, just another example trying to show you the difference between the in-plane needle and the plane of the ultrasound beam. Where on the screen, ideally, if you're doing it right, you should see the whole length of the needle, including the tip. And then out-of-plane needling, where the needle is outside the plane of the ultrasound beam, and you'll see mostly kind of a dot with some reverberation. Now you can't really know for sure which part of the needle you're seeing. Is it the tip or somewhere up the shaft of the needle? Now, that was the discussion of how the needle relates to the ultrasound beam, and so now we're going to go over how our targets may relate to the ultrasound beam. And so we'll often refer to our targets in short axis or long axis. So here's an example here where we've got a transverse section through the mid-forearm, and we see the median nerve in short axis, so it looks kind of roundish or trapezoidal, versus in long axis it looks like a long rectangle on the screen. And for different procedures and different scenarios, we'll orient our targets in either the long or the short axis. A common thing, not always, but a common thing is to identify a nerve in short axis and use an in-plane needling technique to dose anesthetic around that nerve. So when we talk about the axis, we're talking about the target and how it relates to the ultrasound beam. So here are a couple more examples. So this is showing us a short axis target, which is a simulation of a vessel, and we're approaching this with an out-of-plane technique where we just see the little dot of the needle and some reverberation artifacts. So this would be a short axis out-of-plane technique. And here we see our target in a long axis, and we're using an in-plane technique. And this is the common convention or the common approaches to vascular access, but with other procedures and other targets, some of the orientations we use are different. So we talk about the needle as in-plane, target is long axis. Here's a real-time example. This is I believe this was radial nerve or some nerve, and we're seeing it in short axis, but we're approaching with an in-plane technique, and here we see our needle approaching and getting close to that nerve to deliver a dose of anesthetic. A couple of other fundamental things. Now, that procedure we just saw a second ago, that was an example of a dynamic ultrasound guided procedure where as we're doing the procedure, we're actually watching our needle approach the target during the whole time with ultrasound guidance. But in some other procedures, we'll use static techniques where we use ultrasound to mark our landmarks, identify them, and then we put down the ultrasound probe, and then we perform the procedure with better knowledge of where our landmarks are. So some common procedures that we commonly do with more static techniques would be lumbar puncture. It doesn't have to be static technique, but this is how I typically do it, where we identify landmarks with ultrasound, we may mark them with a pen, and then with that knowledge we then guide our needle into the space that we're interested in. We also do that with fluid, joint fluid, sometimes pleural fluid, abdominal fluid. All these procedures we commonly do with static techniques after identifying anatomical structures and landmarks with ultrasound. And here again examples of dynamic. This was the one we saw earlier where we're actually watching the needle approach the nerve to deliver anesthetic. Here again we're watching in real time as this needle cannulates this simulated vessel. And here was an example of visualizing a needle into an abscess in real time. Also here, needle, short axis target, out of plane needle technique, guiding into this simulated vessel. So these are all dynamic examples. A few other things just to note about ergonomics, and a lot of these things might seem maybe silly, or maybe all this is intuitive, you don't need to teach us this, but when I see people make mistakes, when I see people struggle, a lot of times their ergonomics and the way they have things set up is part of the problem. So pay attention to these things, get in good habits early on, and you'll be more successful with your procedures and they'll be easier for you. So a couple of things. You want the screen in front of you. So realize when you do the procedure how your body is going to be aligned and how your face and your eyes, where they're going to be on the patient, and then put the screen somewhere that you can look directly at the screen and directly to the patient without a lot of movement, hopefully just with minimal tracking of your eyes. And this is kind of akin to your speedometer being in front of you on your dashboard instead of being over on the side or in the passenger side, so you can quickly look from the road to the dashboard to your speedometer and back again without a lot of movement. So put that screen in a direct line of sight. And then just some other things when you're doing procedures, you really want to stabilize your limbs. And the operator, I even often tell residents to get a wide base, get their feet down, or sometimes be sitting down if possible for some procedures that are even more difficult. You want to keep your elbows at your side. It seems kind of silly, but you're more stable when you do that. So imagine taking a picture and you're trying to get a nice still picture. You try to hold your elbows at your side, maybe you sit down, maybe you stabilize on a tripod or something like that. Use other things, like use the edge of the bed or use the arm of the chair to help stabilize your limbs as you do these procedures. It's going to decrease some of that tremor that comes on pretty quickly and make you more successful. A few other things before you get started. You just want to make sure you have your settings where you want them, your depth about where you want it, your gain and your color if you need color on where you want it. Most procedures you don't require color, but you want your depth, your gain, your presets kind of set where you want, because once if you're doing a sterile procedure, you've draped, you've gowned, you have sterile gloves on, most of the time we don't have sterile drapes over our machine, so you can't be making a lot of adjustments with your buttons on the machine after you've done a sterile drape on your patient. There are a million different P's that people will talk about with ultrasound. These are the ones that I usually kind of roughly remember as I'm doing an ultrasound guided procedure. I always like to do a pre-scan. I used to not do this as often, but I've gotten in the habit of doing this now. I think it just helps you figure out where your anatomy is, make sure something's not abnormal. The last thing you want to do is go through the whole procedure, get the patient positioned, get them prepped, draped, getting ready to stick, and this is the first time you've looked and you found that their IJ is clotted and you're not going to be able to go there and you have to just start over again. So take a quick look at the anatomy before you prep and drape everything and make sure it looks as expected and that you have a good anatomical target. Then after that you're going to prep. You have to make sure you have everything you need. And I'm not going to go through the exhaustive list here, but make sure you have everything you need right there beside you. You don't want to be halfway through and then realize, oh, I need to go, or I need to have someone else go to another room to grab another tegaderm or gauze that I forgot to bring with me. And then once you've started your procedure, you, again, talking a lot about vascular access, you poke into the skin, then you identify your needle and your landmarks, and then adjust your path as necessary to guide your needle towards its desired target. So the first thing I want to go through is ultrasound guided central line placement. This is one of the common things that we probably all do on a regular basis, and a lot of you may have already done, and so I'll just give you a few of the fundamentals, talk to you a little bit about my approach, what some other approaches have been to help you use ultrasound more effectively in central line placement. A couple things about why. Plenty of studies show fewer complications, overall decreased time. I know there's a little bit more setup time, but because you do fewer sticks and you get it on fewer attempts, overall the time is still decreased in most cases. Fewer sticks, higher success rates, less complications, less arterial sticks, less nerve injuries. You can find abnormal things again beforehand, and then I'd just like to emphasize this last part here. It's the psychomotor and hand-eye coordination skills are different than the landmark technique. So if this is new for you and you've always done your central lines by landmarks, the ultrasound guided methods are going to be different skills. I think I hit on that already. Some of the additional equipment you need beyond your usual central line equipment, sterile gel, and a sterile sleeve. Now some central line kits are now keeping these as part of the central line kit, but not always, so make sure that you have sterile gel and a sterile sleeve cover available. Of course, we're talking ultrasound, so we need an ultrasound machine. And for pretty much all the ones that we're going to be doing, we're going to talk about using a high frequency linear probe and pick a setting. Maybe it's a vascular setting or a procedural setting, but get it in a setting that makes sense for what you're doing. And just reminders about what veins look like. They should be thin-walled, they should be pretty collapsible, they shouldn't pulse, although central veins do have a pulsatile quality that is different from an arterial pulsatile quality, so you'll take note of that. And remember, central vessels that we're talking about here with central access are always near an artery, usually touching an artery. So if you're trying to cannulate a central vessel and you don't see the artery nearby, something's wrong, or you're cannulating the artery, or you've got the wrong vessel. So make sure you're looking for the artery next to the vessel to confirm you have the right one. We talked about these already, and I just want to give you a little bit about the sonographic appearance, a little bit of this pre-scanning. Remember, get the screen in your line of sight. You don't want to be looking to your left and the needle's over on your right. The indicator should be on the left of the screen, and you want to have it, if we're talking about short axis and out of plane techniques, then the indicator should be to your left. It doesn't, because sometimes you're standing at the head of the bed, sometimes you're at the foot of the bed, so it doesn't matter as much how it orients to the patient as much as it matters how it's oriented to you, and it should just match how it looks on the screen. So if it's on the left of the screen, it should be on your left. And before you go to stick the vein, you want to scan the course of it and kind of get a feel for which direction it goes and how does it course up and down in the expected path of your needle. So here might be an example of a pre-scan. Let's go back to that last one a second. So these are femoral vessels here. This is the right femoral artery and the right femoral vein. So we would scan these and ideally find where they're more side by side rather than vertically aligned, so that you have a better success rate and your artery's not in the path of your needle. This is what someone's right internal jugular might look like. Now again, we have the indicator to the left of the operator because it's on the left of the screen, so those match. And then here we see dermal tissue, sternocleidomastoid, and here we've got the internal jugular vein, carotid artery, and the right lobe of the thyroid here. Here's what it looks like more in real time. We see that it compresses, and again we track up and down to see where it's most favorable, where it's more laterally aligned with the carotid as opposed to vertically aligned, so that hopefully you can keep the carotid out of the path of your needle if possible. Femoral veins, so the right, remember the artery is more lateral, the vein is more medial, so here's our femoral vein. Here would be the left femoral artery and femoral vein more medially. And the subclavian vein, it's not been as commonly performed or as commonly discussed as some of our other procedures, but subclavian veins can usually be cannulated using ultrasound guidance and decrease your rate of pneumothorax. And this is what it might look like. You're going to find the clavicle up here. We're in a transverse section, and then towards the feet you should be able to find the subclavian vessels. So here's artery and here's vein. Then after we've identified our vessels, we've decided, yes, it looks like a good target, we're going to go for it. We're going to prep, we're going to drape our skin, and then we need a couple of layers of gel. So now, at this point, we've gotten ourselves sterile. We've stuck our probe where it's easily accessible. You can do this with only one person if need be. You've got to get some gel on your probe. Then you drop your sterile sleeve down on top of the probe, and then you can unravel that sterile sleeve and get ready to do your procedure. And sometimes there's a nice little rubber band that holds that around the top. Alright, we're talking about short axis out of plane technique right now. That's most of the time for my central vessels, this is the way I go, although not always, and there are people who have differing opinions than that, but that's the way I usually like to go because I like to be able to see where the artery is most of the time. So we're going to align our vein in the center of our screen. I like to usually just test the skin with the back end of a Q-tip or the little plastic guard of the needle just to make sure I see, okay, here's where my needle's going to enter. This is where it indents the skin. Is it aligned where I want it to? And then we're going to enter the skin. And then once we've entered the skin, we just barely get into the skin. We don't want to advance much further. Once we enter the skin, we want to make sure we know where the needle tip is. And there's a couple different ways to do that. We can just fan forwards and back until we know where the tip of the needle is, or we can look at it with an in-plane technique. And then only once we are confident and we know exactly where that needle tip is do we want to start to advance it towards our target. So here's a little progressive example. So this is in a phantom model, so this is the artery and this would be the vein here. We have identified the tip of our needle by fanning back and forth, maybe wiggling the little tip of the needle a little bit, and then we slowly advance. And we should see the bright edge. We bring it closer and closer down towards that vein. And then lastly, we should hopefully enter the vein and see the tip of the needle in the vein. And at this point, we should be able to aspirate blood. Now, there are, again, some other techniques. There's a wire and needle technique that seems to work pretty well. That involves a long axis in-plane technique. Pluses and minuses to that one. This is probably the one that most people, if you've done this before, this is probably how you've done this and what you're most familiar with. Here's a long axis in-plane needle technique. Our probe and our needle are both aligned along the long axis of the vessel. We get into the skin and then we can move side to side to find the needle tip before we advance, again side to side, or hold the needle still and move the probe side to side to find the tip before we advance, and then we should be able to hit vessel and withdraw blood successfully. This would be an example of long axis in-plane technique. So we have our vein aligned in the plane of the needle. Now, one of the difficult things here is it's very easy to slide off of that target and even get to the wrong target and get the artery in your view. So you just have to be very careful about that. Not saying it's not doable, but that's something you have to be careful about. And then keeping the ultrasound beam and the needle and this target all aligned at the same time sometimes can be difficult, especially on a patient who's moving or their skin is kind of mushy. But this is what that might look like, where we see, and again, we should see the tip of the needle the whole time before we advance, and then we should be able to watch it enter the vein. And again, here we should be able to aspirate blood, or if you're using a wire and needle technique, you should be able to visualize the wire passing and advancing into the vessel. So we talk about the path. So once the needle is into the skin, we want to adjust the path as needed. So again, we find the tip of the needle, and then, or as we're trying to find it, we only want to move one thing at a time. So, and we don't want to advance the needle. We can move it side to side or wiggle it, but we don't want to advance it until we know exactly where the tip is and we have it aligned with our target. So once the needle's into the skin and we're searching for it, we can hold the needle very still and move the probe, or we can hold the probe still and wiggle the needle to help us identify the tip of that needle. But only move one thing at a time, because if you move both, you won't know. You get two moving targets, it's going to be hard to keep track of both of them at the same time. Some of the pearls that I want you to get, and most of this comes out of practice, not from listening to me talk about it, so the practice portion is the most important part of this. Take time, do the setup right, get your ergonomics right. Even when you think, oh, this is going to be a quick procedure, I got to get it over with quickly, taking time to set up right is an investment that will help you be more successful and help you be more efficient with your procedure over the long run. Find your good spot where the vein is superficial and where it's as much away from the artery as possible. And then once your needle's in the skin and once you've started, really your eyes are on the screen most of the time. And if you don't see the needle tip, don't advance it. Very meticulously identify the tip of the needle before you advance. Get into the skin first, then find your needle tip, then advance. And then once you have the needle tip aligned right over top of the vein, you don't want to push gently on it. You actually need to puncture the needle through the vein. Otherwise, you'll just collapse the vein, and then you risk backwalling it or missing it. So you want to align the needle tip over the top of the vein, over the superficial part of it, and then you want to puncture through it to enter the vein and then advance it in that vascular structure.